All right, good morning. So today we'll go over dementia. We'll finish this up tomorrow. And then, everything okay there? And then tomorrow we'll be going over epilepsy and the seizure medications, the anticonvulsants. And so the pharmacy questions for neurology on step one, I think, are predominantly your medications for Parkinson's, epilepsy, and migraine. Probably those three big categories. So this will be an important one tomorrow. So dementia is officially major neurocognitive disorder, but I don't know anyone that uses that term. So you're still going to hear dementia, certainly when you go into the third and fourth year. And so, of course, we always think of memory loss, the amnesia, but there are other classic features that are part of dementia as well. So there are multiple cognitive deficits. So amnesia is certainly the most early recognized feature. And so in our lecture on memory, we talked about episodic memory, working memory. Both of those are significantly affected in patients with Alzheimer's. And like most memory loss outside of one that we're going to talk about, it's anterograde. So the memory problems are once the disease starts and then ongoing from there. But the remote memories tend to be relatively preserved. It's much more short-term than long-term. So a good episodic memory, would be just like asking a patient, what's the last movie you watched? And that'll be a difficult thing because you kind of have to relive that experience a little bit to remember a recent movie. So that's an early prominent feature. Aphasia, and we think of aphasias as, your Wernicke's or Broca's, like with an MCA stroke. But the whole brain degenerates in Alzheimer's disease. And so your language areas are affected. The key thing, though, with the aphasia is that it's congruent with the dementia, meaning it's in parallel with the degree of memory loss that the patient is having. Okay, this will be important when we consider one condition in our differential of Alzheimer's where the language is affected out of proportion to everything else. Okay, so we want to know, is it congruent or incongruent? And so patients, the vocabulary just shrinks a little bit in Alzheimer's. They use a less precise word for things. They'll more often refer to objects as that thing rather than the specific object. They'll use paraphasic errors as well, just like someone with the Wernicke's. All right, and apraxia, I highlighted the M here because when you think of apraxia, you want to think of a motor problem. And so I think we've talked a little bit about apraxia, but we have these thousands and thousands of these motor programs in our brain that allow you just to do everything automatically, right? Showering, driving here, typing. These are all just things that we've got a motor program for these. They can be selected automatically. And so in a condition with apraxia, patients have a hard time just selecting these pre-programmed areas in the brain. And so by definition, in apraxia, so a patient may have a hard time doing something such as dressing. Okay, there's a program for dressing. And when that degenerates, just the act of dressing can be very difficult, and they need help. And it's not because they're weak, it's not that the hand can't move, it's just that the motor program for dressing is impaired, right? So we see apraxia, but by definition, it's not because of weakness or sensory loss or ataxia or something like that. So they all have to be things that are previously learned tasks, obviously, and then as they degenerate, they lose the ability to do that. And I hate to repeat a story. I don't think I've told this class this, but I work with a neurologist who said he has a parallel parking apraxia. And I reminded him that an apraxia has to be for a previously learned task. So if you knew how to do it and then you forgot, well, now we're dealing with an apraxia, but that's not apraxia by definition. Okay. Little bad neurology humor there. So an agnosia, you want to think of that as mainly a sensory deficit. And so visual agnosia, We talked about prosopagnosia, how good our brain is at just recognizing facial features and linking that with the name of someone. And so that would be an example of an agnosia. It's a failure with sensory integration. Phonagnosia is so difficulty recognizing someone's voice. And again, just when you think about these things, it's just amazing how good our brain is. The little intonations, and we can just hear someone's voice and we recognize who that is. So as your brain degenerates, we're just not going to be as good at that. So we're going to have difficulty reading. That would be another agnosia. Time agnosia is quite common in Alzheimer's, and they're just really poor at sequencing like the events of the last week and putting it together, that kind of a thing. All right, and executive function. Remember when we talked about the dorsolateral prefrontal cortex and the task setting, the monitoring, planning, organizing, sequencing, that kind of thing. That's affected. And so I like to ask patients that have, I suspect having dementia, things like, well, who pays the bills at home? Because that takes a little bit of planning and organization and all of that. And so if your patient that you're seeing for memory loss always used to pay the bills and then stopped 6 months ago and the spouse is taking over, well, there's a story there. Something happened, and that will be an important clue for you. All right, so mild cognitive impairment, we see this a lot, individuals that are having some issues, usually memory related, but not absolutely. So I'll talk about some different types. So they're at risk. They're having some mild memory or other cognitive complaints. And you would see this is pretty common. So between 60 and 64, we've got about 6.7%, up to 10% between ages 70 and 74. And so we divide mild cognitive impairment into amnestic, so the memory loss is the issue, or non-amnestic, so this would be more like maybe they're just having some word-finding difficulty, or maybe some more visual spatial disorientation. These patients would be at a higher risk for merging into Alzheimer's dementia. Things like word-finding difficulty, that is so common just with normal aging. Almost everyone I talk to over 60, 65 has some word-finding difficulty. You know, so we want to recognize that there are a lot of common complaints like that with normal aging. Doesn't mean someone's, coming down with Alzheimer's. Okay, but overall, there is an increased risk of progression to dementia, 50 to 80% over a 5-year period of time. And again, it's the amnestic form that we're more concerned about, to separate from normal aging. And so I showed a picture here of myself here. This was a few years ago. I looked for an entire day for my wallet and keys. I mean, turned the house upside down. And here, when you put the groceries in the fridge, I put my wallet and keys in there. So, these things happen to people. But, patients are going to be, they'll compile these and be very concerned and will come to see you worried they maybe have Alzheimer's, maybe they have a family member that had Alzheimer's dementia. And so one important thing to remember, though, is that a classic feature of Alzheimer's is that they have no insight. And so almost always it is not the patient coming concerned about their memory loss. It's usually the family members that are concerned, and the patient is downplaying it and saying, it's not a big deal. I think I'm fine. So I'm more concerned with a patient who is unconcerned about memory problems. I'm less concerned about someone who's maybe anxious because they've been forgetting a little bit. Okay, so anytime we have someone with memory loss, we do metabolic testing. There's more that we order than this, okay, but I'm just a couple of examples. Remember, B12 deficiency can give you cognitive, so we always check for B12. It's just at the drop of a hat in neurology because it can do so many things. Check for thyroid dysfunction because that can be associated with some memory issues. We don't necessarily do an MRI scan in every individual that comes in with some memory issue, but if you do, you're looking for atrophy, rarely a mass lesion or strokes, but usually there are going to be some other symptoms that would tell you that that's what's going on. And we have different cognitive tests that can be done, the mini mental status exam or the MOCA. And so it's good to do that as a baseline the first time you see the patient. and so that then when you follow them, you can retest and see if they're changing at all. Sleep apnea is something that is commonly associated with some cognitive deficits. And just imagine waking up hundreds of times in the middle of the night, you're not aware of it, and in an older individual, that's going to be a big issue. So we'd want to think about this, ask the spouse, do they snore, do they have apnea episodes? And one thing that can be kind of helpful for sleep apnea is early morning headaches are kind of a classic feature of that. So if someone's waking up with bad headaches in the morning, that might suggest sleep apnea. And then finally, look very carefully at the patient's medications, because there are many medications that impair cognitive function. So anything that is an anticholinergic, and there's so many medications that have anticholinergic properties. And so this would be the first thing you would do in someone that's having some memory issues. If at all possible, stop these medications. So the tricyclic antidepressants like amitriptyline and nortriptyline, remember we use these for headache prevention. They're used for a lot of pain syndromes. I would say they're more often used for that than they are by psychiatry for depression, because they can be quite effective for pain. Incontinence medications, remember we talked about oxybutynin, which acts on those muscarinic receptors on the bladder, but it's anticholinergic, so it can affect memory. A scopolamine patch, this has more to do with histamine and benztropine. We talked about that, it's used for tremor in Parkinson's disease. So all of these, and remember your clue in terms of, if a patient is on these, is you're going to block the muscarinics for the parasympathetic system. So the patient is usually going to have a dry mouth, constipation, some drowsiness and sedation affecting the muscarinic receptors in the brain, urinary retention. Okay, so really we try not to use these medications, especially over the age of 65. And at the VA, if I want to put a patient on, let's say, a tricyclic antidepressant for their headaches or whatever, there's a lot of monitoring that I have to document, like in a month, see how they're doing, that kind of a thing. So just remember, be careful using these in the elderly population. So antihistamines, certainly if someone's using those for sleep, that can impair memory. The opioid medications, big time effect on cognitive function. Benzodiazepines, okay, such as Valium or diazepine. The medications for Parkinson's, I already talked about benztropine, but remember over 65, we really try not to use dopamine agonists in Parkinson's disease because of the memory issues. A lot of the medications that Dr. Everett has gone over with you, the neuroleptics, antidepressants have a cognitive function, and tomorrow when we go over the anticonvulsants, there are some that impair memory. So the point here is when someone is having memory issues, we want to have a differential, and this would be very fixable. If a patient is on a medication for, let's say, depression, and it's maybe working for their depression, but it's making them confused, well, switch them to another antidepressant that is less likely to cause confusion. So that kind of a thing can sometimes just fix the problem. Okay, so here are the conditions that we're going to go through today and tomorrow. So I've already talked about drug-induced, and so we'll spend most of the time today talking about Alzheimer's, and then most of the time in the next hour going over the things that sort of look like Alzheimer's but aren't. Okay, so if you just have someone that has dementia and you guess Alzheimer's, you're going to be right most of the time. Okay, so as a rough guide, the incidence of Alzheimer's is about 1% at the age of 60, so not very common, and roughly it doubles every 5 years after that. Okay, so we get up to 32% by age 65. Now, it doesn't just continue at that same rate. It actually levels off when someone gets into their 90s. So this is kind of a guide, from 65 to 85. But you can see that, in a study of 160 people over the age of 93, only 19 of them had no memory issues. Okay, so we see this more often than not in the elderly. So I said if you guess Alzheimer's, you're going to be right most of the time, and you'll be right 70 to 75% of the time. Okay. And so in 2015, $200 billion healthcare costs on dementia. And with the elderly population, the fastest growing segment of the population, this is going to be a real issue here in the coming years. All right, so there are definitely genetic factors, genetic susceptibility factors for Alzheimer's. Most cases are sporadic. So there's like, one had a cousin maybe that had Alzheimer's, but most individuals just, it's a sporadic condition. If you have 2 or more first-degree relatives, now you have a substantially increased risk of Alzheimer's. Okay, so we're going to talk about this as a bottom line. We have a problem with the amyloid beta protein. It can be overproduced or reduced clearance. And so this is kind of, if we just boil down the pathophysiology of Alzheimer's, it involves the amyloid beta protein. Okay, so we all have the amyloid precursor protein. That's fine. That's normal. It appears to act at neuronal synapses to help them function normally, and also important for formation and repair. All right, so no problem having the amyloid precursor protein. Okay, and important when we talk about Down syndrome, which is trisomy 21, just to remember that the amyloid precursor protein is on chromosome 21. So the problem has to do with the abnormal cleavage of the amyloid precursor protein. Okay, so if we have a beta or gamma secretase cleavage, then this can result in this amyloid beta protein. Again, that's what we don't want. And so this is when things begin here in this complex cascade of things that go wrong in the brain with protein folding and all of that. It's when we have this amyloid beta protein. Okay, so this is extracellular. In Dr. Deish's lecture in just a few days, he's going to go into the senile plaques in more detail than I will. But these senile plaques here consist of the amyloid beta protein, and they are extracellular. Okay, and then as things get worse, we have more clumping and aggregation of these proteins, and the aggregated form then is really toxic to the nervous system and significantly impairs with how the neurons communicate with each other. Okay, and then this leads by a mechanism that I don't think is understood that well to clumping of tau. Okay, tau is a microtubular associated protein, and it's important to stabilize the microtubules and their function. But in this process, tau gets hyperphosphorylated, which leads them to clump together, and this forms the neurofibrillary tangles. Okay, so you need to associate the senile plaques and neurofibrillary tangles with Alzheimer's. Neurofibrillary tangles are in the cytoplasm of the neuron. So remember, the senile plaques are extracellular. Okay, and so this does a lot of things. It's inflammatory, you get dysfunction of the mitochondria, and this leads to just a progressive misfolding of tau, and we get neurofibrillary tangles throughout the brain. Okay, so remember, neurofibrillary tangles are here in the cytoplasm. Okay, whereas the senile plaques or the amyloid plaques are extracellular. Okay, and so here's just another drawing of that. So I mentioned last time there are just a few things you definitely need to be able to recognize in terms of neuropathology for this course. A Lewy body, you've got to be able to recognize that. And here in Alzheimer's, you need to be able to recognize a neurofibrillary tangle, kind of outlining the neuron here. And here is amyloid. Okay, I'm going to let Dr. Deisch talk about the different staining and all of that here in a few days. So here's a really nice drawing that Samantha Harris, who just graduated here a few months ago, drew to kind of show this. So here we have the amyloid precursor protein. Here's the A-beta peptide. Okay, and so if we go this route, where we have the alpha cleavage, okay, that you can see kind of separates this A-beta protein. And then you can have a gamma cleavage from there. So this is normal, not toxic. Okay, but if we have a beta cleavage here, okay, here's the beta cleavage site. So you can see this separates the amyloid precursor protein, and then you get the alpha secretase cleavage here, well, now that is going to lead to this A beta protein. Okay? We can also have an initial gamma cleavage, but the big point here is if we're not going initially through the alpha cleavage, then we're going to end up with this A beta protein. Okay, and so again, those can clump. We get these A beta aggregates. So these are the senile or amyloid plaques. And this leads to another cascade here with tau hyperphosphorylation and neurofibrillary tangles. Okay, so using that, we can give a few examples of some genetic conditions that are associated with Alzheimer's. So remember, the amyloid precursor protein gene is on chromosome 21, and there are more than 50 known mutations that altogether make up about 10 to 15%. And you can see these are quite distinctive. So mean age of onset is 49. Remember, Alzheimer's is very uncommon in the general population under the age of 65. Okay, so a lot of these hereditary conditions start early. Okay, mechanisms probably increased amyloid beta formation. Okay, there are different mechanisms. So you do not need to know the 50 mutations, but you definitely need to know about trisomy 21. Right? So we get an extra chromosome 21 and an extra amyloid precursor protein gene. And so these individuals almost all have Alzheimer's by the age of 40, Down syndrome. Okay, the other two to know are the presenilin 1 and 2. So presenilin 1 is on chromosome 14, presenilin 2 is on chromosome 1, and both of these through an initial gamma secretase mechanism lead to development of the Alzheimer's. These also tend to be an early onset form of Alzheimer's. So again, if you've got a younger individual with Alzheimer's, we're now much more primed to think about these genetic conditions. The more common one here is the presenilin 1, which makes up about 50% of the early onset Alzheimer's. So really, we don't see these very often. Much more likely it's sporadic. Now, much more relevant in terms of something that we see all the time are the genetic mutations for the late onset Alzheimer's. And this involves apolipoprotein. Okay, apolipoprotein, normally involved in lipoprotein metabolism, has some function here on for lipids that is good. Okay, there are three isoforms of apolipoprotein. Okay, the one you want to have is the ApoE3. Okay, this is actually protective against Alzheimer's. It may actually act to remove the any A beta protein. Okay, and with more and more people doing things like 23andMe genetics testing, you can download that and you can find out what isoform of apolipoprotein you have. So a lot of patients come in, you get the report, and they want to talk with you about it. So this comes up all the time. The dysfunctional forms are the ApoE2. This is more associated with vascular issues, and the ApoE4, which is seen in about 14% of individuals. This is the one that is as a risk factor for Alzheimer's dementia. Okay, and in fact, if you have two ApoE4 alleles, you have an 8 to 12 times increased risk of getting Alzheimer's by the age of 75. Okay, now do we do this routinely? No, in fact, we don't recommend doing this testing if patients ask. They want to know what their chance is of getting Alzheimer's. And there are several reasons. It's a susceptibility gene, but not determinative. So even if you have two ApoE4 alleles, it's not a guarantee. It's not like Huntington's. If someone has that trinucleotide repeat, they are going to get Huntington's disease. But it's not absolute with this. And 40% of patients with Alzheimer's do not have an ApoE4 allele. Okay, so you have to do some, counseling when patients bring this in. You can see there's a little bit of a decreased incidence here of ApoE4 alleles, less common in Chinese populations, higher in African Americans overall. And don't worry about it, I just that's kind of interesting. The difference between the good ApoE3 allele, that's the one you want to have, and the bad one, structurally it's not a huge difference looking at it, but that small change, that small conformational change has a very significant clinical impact. It's a change in a single amino acid residue. Now, what can be done? Yes, question. Is there a hereditary component for ApoE4? Yes, there is. But it's rather complex. And so maybe if you want, email me about it. I can give you some more information. Now, so we want to know you can't impact your ApoE4 allele. You've either got it or you don't. And so what are things that can be done that could overall decrease your chance of getting Alzheimer's? And so there's a huge amount of information now about epigenetic factors for Alzheimer's. And this is very, very significant. I would just write here in big words over here, vascular, right? Because anything that affects, when we talk about a vasculopathic patient, remember you're diabetic, hypertensive, dyslipidemia, smoker, all of those are big-time epigenetic factors for Alzheimer's. And so smoking, too much alcohol, poor nutrition, kind of tying in with that vasculopath patient, high chronic stress, childhood trauma, a sedentary lifestyle. These are all things that promote risk of developing Alzheimer's, so they result in an epigenetic acceleration, increased risk. So we want to be doing exactly the opposite. So we have really good evidence to suggest if you want to prevent this, lower your chance, or at least delay, exercise is really significant. So meta-analysis of 16 prospective studies showed a 45% reduction of Alzheimer's for those who are physically active. And it appears that the younger you are when you start being physically active, the more benefit you're going to get from that. Okay, we also know that individuals that have a more advanced education at least have a later onset. We think that is probably just from more synaptic density, more memories, more things that you've learned, language, all of that. If you speak multiple languages, that's also another positive thing. And individuals that play a musical instrument also just tend to have a later, and again, it may just have to do with more of the brain is being active and more synaptic density, and so it just appears later. Okay, so this part I'm going to go over just really quickly because Dr. Deich will be talking about this. We have diffuse atrophy of the brain, the association cortex. Remember, that's where your long-term memories are stored. Those are definitely affected, and so in a later stage of Alzheimer's, there will be difficulty even remembering remote things. All right, so we have widespread loss of cortical neurons, especially in the hippocampus. Remember, the CA1 region is especially important in that process of laying down new memories, and those are selectively affected in Alzheimer's. We have a dropout of the areas at the base of the brain that produce acetylcholine. Remember, the nucleus basalis of Maynard is one of those important areas that you remember. And so we get senile plaques, neurofibrillary tangles, and granulovacuolar degeneration in the area of the hippocampus. And that one I'm going to let Dr. Deich explain here in a few days. Okay, so just a little bit in terms of the clinical presentation. Presents with an anterograde amnesia. So episodic memories, recent episodic memories are significantly impacted. Working memory is also affected. So what would be a working memory? The spouse says, could you pick up these 5 things at the grocery store? 5 things to remember. Just like you're trying to remember things in a lecture right now and try to put these things together. That's difficult. So or if they're given a phone number to remember, they're just not going to be able to remember those 7 digits. They've got to, write that down. Learning, kind of tying along with this, it's very difficult to learn something new, even in the early stages of Alzheimer's. So you get something, a new device for your TV with a remote control, and just looking through the instructions, figuring that out, it's going to be very frustrating for someone with early dementia. But the semantic memories are intact for a long time in Alzheimer's. So they're still going to be good with, state capitals and just facts and things that they've learned. That's a much, much later involvement. Okay, and I mentioned loss of insight is just hallmark. So it's concerning when the patient is unconcerned, and it's the family members that are concerned. Also very common, you want to ask, what do you do? Do you have hobbies, things that you're interested in doing? And almost always in the early stages of Alzheimer's, they just kind of lose interest in those things. Okay, so I see this at the VA a lot, someone they have always enjoyed working on old cars or doing woodworking, things like that, and they just kind of stop doing those things. So remember, aphasia is a part of it. It's congruent with the memory loss. Apraxia, and so you just want to ask about a whole bunch of things, things like, if someone likes to sew, driving a car, all of these things that we have these motor programs for, they just become somewhat impaired over time. Agnosia, and remember that the language part, that's going to be more left hemisphere hippocampus, working with the language areas in the brain. The right hippocampus is more for the visual spatial. Remember the London taxi drivers that have more big right hippocampus. And so spatial disorientation is an early symptom. Okay, so I hear this all the time, get lost driving, even when they live, in a place where they've lived a long time, but maybe they go once a month to Costco or something. It's a little bit of a different route, and they can't quite remember how to get there. They take the wrong exit. Really common. And in an advanced stage, believe it or not, see this all the time. They get lost in their home, larger home, trying to find the living room, and just get turned around. So here's a really typical interaction that I'll have with a patient with Alzheimer's. So I'll ask them what year it is, and they're really good at deflecting. Okay, and so they'll say something, well, I'm retired, I don't pay attention to the date. That's okay, give me your best guess. And so the patient says 21. And so, we might say that. What year is it? 21. But you want to really know, do they really understand that? So what's the full year? 21. And so I usually will then try to say, well, what year were you born? Most people can remember that. And so the patient might say 1941. Yeah, right. Okay, that's what I mean by the full year. So what's the full year now? And the patient then will often say 1921. Okay, and so superficially, patients appear pretty normal, and so we really have to, especially at an early stage, get into more details. Don't be embarrassed to ask these kinds of questions. And oftentimes you'll be surprised at what a poverty of memory issue there is, despite on the surface appearing pretty normal. Okay, as we get into more advanced stage, judgment's impaired, difficulty with problem solving. Again, I mentioned asking who takes care of the finances. That's just a really good question to ask. Bills getting paid twice or more often, not getting paid at all, foolish financial, decisions, that kind of a thing. Okay, but until a much more moderate to advanced stage, we have preserved social skills. So these patients come in, and typically no one, nurse or anyone in the check-in, or just, you're casually talking with the patient, appears like a normal, nice, normal, older individual. Okay, so they're superficially looking pretty normal. Okay, one thing we see a lot in Alzheimer's, in a number of neurodegenerative conditions, it's called perseveration, where patients, they keep repeating the same thing over and over again. And maybe you're doing memory testing, and you're asking them to remember 3 objects or 4 objects or whatever, and then, later on they may just come back with one of those objects. They keep kind of, focusing on that. For years, I had a patient, he passed away recently at the VA, he had Alzheimer's, and he told me the same dirty joke every time that he would come in. So I would know it was coming, would apologize to the medical student, okay, you're going to hear a bad joke. And in the end stages, he would sometimes tell that joke in the same visit several times. So that would be an example of perseveration. All right, as we get to the more advanced stages, so early on, they're outgoing, they're talkative, and then they become withdrawn and develop some apathy. And now we get into a lot of behavioral issues. So we want to be really in tune to the high incidence of depression and anxiety that someone with a more advanced Alzheimer's has, and we want to treat that if we're noticing those features. And so then they can get very agitated, restless, occasionally violent with family members. Okay, so we ask about that. Delusions, that the spouse is having an affair or something like that. Sometimes hallucinations, but again, this would be a late feature. Okay, but it's important just to recognize that behavioral symptoms have more of the burden for the family member typically than the actual memory loss as we get into the late stages, because we've got a really nice individual and now they're violent and they're upset and they're having these strange delusions. And so we often work together with psychiatry at this stage to try to really, balance things well in terms of medications. Okay, so early on the patient does very well with motor function. Their walking is good, but as a late feature, they slow down. They may shuffle their gait a little bit. They may develop superficially, some features of Parkinsonism. They don't have Parkinson's disease, right? This is just Parkinsonism from advanced dementia. We don't treat these patients with dopamine medications. Okay, and remember, we look for frontal lobe release signs because just anything that affects the whole brain, including the frontal lobe. So that palmomental, the glabellar reflex where you tap on the forehead and the eyes just keep blinking. We'll look for those kinds of things. Right, and then eventually the patient is in a vegetative condition. They don't recognize anyone and stop responding, and usually death is due to an infection of some sort. So pneumonia, bladder infection, something like that. Yes? Mm-hmm. Yeah. 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 Yeah, so the good question, we see that quite a bit, that the individual is just saying, I'm hungry, even after eating. So that would be an example of a perseveration, where just oftentimes patients will just fixate on one thing. And so I doubt there really was any real hunger there. It was just kind of this loop brain thought that just kept going over and over again. So that would be more likely, yeah. So just a few kind of pearls here. You need the family members present, obviously. So you really want to find out, what's kind of the first thing you remember. And so a lot of the clues will be from family members. Since the patient is telling you, I'm fine, there's no problem. So I like to ask, when was the patient last normal? Okay, and how far back? That'll give you an idea about when this began. So some good questions. Again, who takes care of the bills? Who prepares the meals and cleans the house? Maybe the spouse loved to make new recipes and all of that. And yeah, we noticed about 4 months ago that we were just getting takeout all the time, and things seemed to change. A loss of interest in hobbies and other activities. Does the patient still drive a car? And if not, what happened? And you'll get a story about getting lost or something like that. This is one of the more uncomfortable things that I have to do as a neurologist, is when someone has dementia at a certain stage, you need to tell them that they can't drive anymore, and you need to report them to the DMV. And so, again, you have a patient who has no insight that they have a problem, and now you've got this mean doctor that is, saying they can't drive anymore. And so there's often a lot of friction, at that point. Yes?
Do you tell them that you report them?
Yes.
Do you have to?
I don't have to, but then when I see that patient back in follow-up, they're going to say, I got this from the DMV. What kind of a horrible person are you? And so I found it's much better just to be upfront and say, you know what, the law in the state of California requires me that when someone has memory loss to a certain stage, I'm required. So I can kind of make the state of California the bad guy, a little bit. So that can maybe deflect just a little bit. Now, over time, they're going to forget that you did that, right? So it'll just be a difficulty, in the initial encounter. But I am often surprised. I saw a patient not too long ago on a 30-point cognitive test. He scored 12, so he's pretty demented, and he was still driving the grandkids to school every day. And the daughter was there, and she could hear, he didn't know basically anything. And so I assumed she would be on my side and realizing this is not an individual who should be driving. And they were both really upset that, I can't imagine letting my kids ride to school with someone that was that demented. So anyway, but it's just something you don't want to forget. You don't want to lose your license. You're following the patient who clearly should not be driving and you didn't do anything about it. Okay, now when we're doing these formal cognitive tests, again, you have a patient deflecting, they're wanting to minimize, and so sometimes they'll get agitated. And if that is the case, then I will just say, okay, we're going to come back and do this later, and I try to find an interest that the patient has, preferably something that I know a little bit about. So if they like a sports team, so hopefully it's basketball, because one sport that I follow a little bit. And so I can ask them, okay, how'd the Lakers do last year, or something like that. And so you have a little bit of a conversation. Who's playing for them this year? And maybe even the fact that they watch every single game, they can't tell you any of the players, So that would be kind of a way, maybe a less formal way of getting information. All right, so if we do an MRI scan, we're going to find atrophy, especially involving the hippocampus. If we do metabolic tests of the brain, which are still mainly done for research purposes, although we think these are coming to our practice soon as just more helpful tests. We can do PET or SPECT scans, and in that case we see less metabolic activity, especially in the temporal parietal lesions. So think of the hippocampus connecting with these areas like visual spatial in the right hemisphere, more language in the left hemisphere. So we're going to see abnormalities there. And what is really very helpful is PET amyloid imaging. Again, still mainly done for research studies, but you can actually visualize the amyloid plaques in the brain. We don't see these on an MRI. Okay, and of course, Dr. Deich can make fun of us for having the wrong diagnosis at autopsy, but I think we're pretty good, usually making the right diagnosis of Alzheimer's. So here's a normal brain in an older individual. We can see that there are some sulci that are fairly prominent, but in Alzheimer's it's much more prominent. And again, look at the temporal horn of the lateral ventricle, this dark space here, which is normally really small. So I've got a nice healthy hippocampus here, and notice they're much larger here because of the hippocampal atrophy. So if you see someone that has mild cognitive impairment clinically, they don't meet the criteria for definite Alzheimer's dementia, and you do an MRI scan and you find this, the patient has Alzheimer's dementia. Okay, and another one I've showed you before, again, normal hippocampus and big temporal horn of the lateral ventricle here, the white space on this MRI sequence. And so again, that's what we'd see in Alzheimer's. PET studies, yes?
I have a question. These people who are getting the amyloid plaques and the tingles, are they getting them their whole life, and then it just starts affecting them when they're older?
Yeah, so you're anticipating, I think, the next slide. The question was, how long are you getting these before? And it appears to be like 10 to 15 years before. And so someone is actually getting the pathologic changes of Alzheimer's in the brain a long time before they're symptomatic. It's kind of like Parkinson's. Remember, you're starting to lose substantia nigra 8 to 12 years before the onset of Parkinson's. And so that's why there is a lot going on to try to figure out how could we make a really early preclinical diagnosis, in these patients, and then maybe would have some treatment intervention. So it's a long time before. So here we can see in blue the hypometabolic activity in sort of a temporal parietal region. That would be consistent. Okay, and red here is amyloid. So when we do a PET study for amyloid, you can visualize it. So this is where, done in these clinical studies, You may have heard of all of these monoclonal antibodies against amyloid, all these studies that are being done. And this is a patient pre-treatment and after treatment, and look at the dramatic reduction in amyloid. And so we can visualize this on a PET scan. We can actually knock out the amyloid, but we can't really prove that these medications are helpful, probably because this has already destroyed so much of the neuronal networks that then giving this, even though we see imaging improvement, we don't see much clinical improvement. So that's where maybe if we could diagnose these before patients are symptomatic, then we might be able to really do something about it. So here was one study here showing you amyloid at baseline with placebo, no change. And again, look at the significant improvement when we give this particular monoclonal antibody. So this is a pretty, I would say, hopeful direction for Alzheimer's, and probably something that we'll be doing more of. Now, in terms of just the cascade, so I mentioned the pathologic features of Alzheimer's are occurring 10 to 15 years before patients are symptomatic. So if we look at a very early stage, the changes, dysfunction of tau and amyloid occur years and years in the brain before someone is symptomatic. And so we're going to see a continual rise in those, tau and amyloid. Okay. PET scans are actually a pretty early indicator. So again, if we could do those amyloid PET scan, that would be something else pretty early. MRI scan does happen quite often. Someone's in a car accident, they end up getting an MRI scan of their brain, and you find fairly significant atrophy. Well, now we're concerned about that patient. They're not symptomatic yet, but this may indicate that they have the onset of a neurodegenerative process. Okay, and now we're way down here. So when we talk about mild cognitive impairment, if that's the early symptom of Alzheimer's, just recognize how far down the line that actually is. And then of course, someone finally is developing definite features of Alzheimer's. Okay, so when do we want to do an MRI scan? There's a lot of debate about that, but if anything is atypical, unusual, different than what I just described to you, we see in most patients, we'd need to do an MRI scan. Obviously, you do a careful neurologic examination. If a patient has anything focal, they've got a little hyperreflexia on one side, a little bit of sensory loss on one side of the body, maybe a visual field deficit. Well, now we're thinking about something focal in the brain that is causing the memory issue. They need a brain scan. Okay? And we always do, as I mentioned, a metabolic workup. We love to find something like B12 deficiency. That doesn't happen very often, but you'd obviously be kicking yourself if you've got someone with memory loss from B12 deficiency for a year and it just wasn't checked and diagnosed. So overall, most patients die within 6 to 12 years of the onset of symptoms, but the range is really broad. I followed for years a pediatrician who had Alzheimer's for well over 20 years, did quite well for a long, long time. Again, probably more education, synaptic density. We know that those patients have overall a better course. So I'll finish with this here in terms of treatment. And so the one that would be highest yield for boards would be donepezil, but I want you also to know about rivastigmine. These are both centrally acting acetylcholinesterase inhibitors. Remember that other neurotransmitters are inactivated mainly by reuptake. Okay, acetylcholine is unique. It's mainly inactivated by the enzyme, acetylcholinesterase. So when we give an acetylcholinesterase inhibitor, you get a lot more acetylcholine. That's your most important neurotransmitter for memory. Okay, and so, but, we don't want to, these have I would say, a modest benefit. Okay, so patients can come back and their family says, yeah, they're a little bit better, but these are obviously not curative, right? So you can get, especially in the first year and a half or so that you're using these medications, the patient may have some improvement. So we like to use these. They're, generally well-tolerated medications. The reason I want you to know rivastigmine is on our lecture tomorrow. We're going to talk about another dementia syndrome, and that one in particular tends to respond to rivastigmine. But they're both acetylcholinesterase inhibitors. Side effects, well, if you increase acetylcholine, Just think about the parasympathetic system. We've got more acetylcholine stimulating the GI tract, so patients get stomach cramps and diarrhea occasionally. And kind of along with that is nausea and vomiting. I would say my experience and studies show most patients really have very minimal side effects with these medications. So they're well tolerated. Okay, and then finally, if we're getting to a more moderate to advanced stage of Alzheimer's, then the medication that can be used here is memantine. Again, a mild, modest, small benefit. But this acts on glutamate. Remember, your classic excitatory neurotransmitter. It may somewhat decrease the release of glutamate, but it's also an NMDA receptor antagonist. Remember, the NMDA receptor appears to be your final end pathway frequently for neuronal death. Okay, so these are the two medication classes for Alzheimer's. And then as the last point, just remember, depression, anxiety, delusions, very common in an end stage of Alzheimer's. And so those respond well to antidepressant medications. So we don't want to miss out on that. And that will help a lot with the burden that family members are dealing with in patients with an advanced stage. All right, I'll see you tomorrow morning.